Hey, good afternoon. Today we have Dr. Jagannath Devan with us. He's a pediatric infection diseases professor in University of California, San Francisco, and he's also a clinical researcher and a data scientist, and working on a lot of research on pediatric TB tuberculosis diagnosis. He has a passion for pediatric patients, and also working on biomarkers and new tools for pediatric TB diagnosis. Good to have you here.
Oh, thank you for
It's a
having
pleasure
me.
talking to you also. So Dr. Devan, just you have been in the realm of research of new tools and diagnosis of pediatric population. So could you please update us about the products in the pipeline, products probably in the early implementation phase?
Yeah, thank you. And it's definitely an exciting time for pediatric TB. There's a lot of interest at this meeting. And I think when we think about the pipeline for TB diagnostics for children, I think there's a couple factors that we consider. One is, can we make the samples easier to collect and to test? So, for example, expert-based testing or other molecular-based assays, can we make that a little bit more feasible to collect in children, such as through swab-based testing? There's been a lot of work presented today as well on stool-based testing. So that's one aspect, is like, how can we improve overall feasibility? The second part is, how can we take tests that exist and really improve them in order to get them closer to an assay that would be relevant for children. So for urine-based tests, how can we utilize markers such as LAM and look at certain populations, such as individuals that have severe acute malnutrition, and make these relevant for them. And then the third piece is really like, how can we take existing tests that seem to be working well for adults and really try to translate them more to children. A good example would be CAD and other AI-based tools that, as we know, continue to show that they're fairly promising for adult triage for TB, but there really needs to be more work in terms of fine-tuning and validation for children. And then the last piece on the pipeline is, what's the future? What can we really discover? Because especially when we think about current tools on the host side, so host-based biomarkers, we know that children have an evolving immune system, a different immune response, a different phenotype than adults. And so we really need to put in the initial translational and basic work to discover markers that work for children. And again, with the mindset of, what's going to be feasible from a collection standpoint? Is it going to be a point of care blood test, a point of care urine test? And so there's really a lot of exciting work that's been presented at this conference on new markers that are unique to children, recognizing that they'll likely have specific tools.
Yeah, so with pediatric TB diagnosis has been a challenge forever, and now every year when we have global review or global TB report flashes that the gap in pediatric TB diagnosis, and also calls out for a need for new tools. And this year, interestingly, I found that it clearly called out a need for a CAT tool less than 15 years and below, and also probably now there will be a lot of research happening in that dimension. So what are your thoughts? Do you have experience on, because I know that you have been part of many pediatric CAT studies, and also sound is another area which has been also getting some traction. So could you please share some thoughts and experience?
Absolutely. Yeah, I mean, I think just to take a step back to say the role of chest x-ray for children for imaging, I think we know that because they have polyvascular disease or low bacterial load in their sputum, that many of the bacteriological tests, whether it's a molecular-based test, definitely culture, they're just going to have reduced sensitivity for children overall. And when we think about, at a population level, how children are diagnosed for TB, it really is through clinical signs and symptoms.
Correct.
And a chest x-ray is really a fundamental aspect of that. At the same time, we have to recognize there's a huge number of challenges for children, whether it's just being able to recognize the unique abnormalities for childhood TB, including hyaline-lymphadenopathy, which can be quite challenging, but also just obtaining a chest x-ray, getting a quality image in a community-based setting for a child can be challenging. And so I think that's where I think CAD can play an exciting role, especially from a diagnosis or triage perspective. Can we have more reliable reads? Can we make it easier to read images or to interpret images for children? Because again, that X-ray interpretation will play an important role for the majority of TB diagnosis, and so it's great to see the excitement for CAD for childhood TB, just because I really do think that it plays that important role. In terms of what we're working on, I think a big aspect and fundamental, and maybe you can speak to this as well, is how can we translate the adult based algorithms for children. One level is just validating that, and the second level is kind of how can we fine tune. And I think a core part of that is building a repository of well characterized images that have a clear reference standard, expert read, and that's something that myself as well as colleagues in this Capture consortium that we'll be presenting on tomorrow will kind of highlight how we've really worked as a community, because I think because the investigators and greater pediatric TB community really recognize it's important to have worked together to share images, build a repository so we can enable this validation and discovery. In terms of your other question around sound-based tools, I think it's a similar extension, right? How can we take advantage of the fact that these are so easy to collect, right? Whether it's a cough sound or a lung sound-based tool, or there might be others that, again, are non-invasive, simple to collect, clearly are exciting to think about for applications in children. And so how can we envision a way in which we can be developing algorithms that can help either with detecting lower airway abnormalities or increasing our confidence in TB diagnosis in parallel to adult algorithm development, again, recognizing, similar to host-based markers, that we're going to need likely unique algorithms for children to make them work.
Cool. So just to understand, get a clarity on this data sets you are creating. These are data sets of open source data sets of pediatric X-rays with clinical parameters already mentioned and being diagnosed clearly as tuberculosis, either by clinical parameters or by microbiological parameters. Is that correct?
Yeah, so these are images that have been collected as part of TB diagnostic studies. And so it's going through that work of identifying, who are really the leaders in pediatric TB, working together to build a consortium to say, can we pool these X-rays together, build a data set, like you said, that has clear clinical, microbiological definitions, clear expert reads, and then create an opportunity for one independent validation of existing algorithms that might be promising, but then also create opportunities for groups that want to collaborate and partner in order to fine tune or develop some new algorithms for children.
Perfect. So our CAD solution has been CE certified for 3 years and above, but that was specifically but the WHO recommendation is 15 years and above. So though we have seen there is a significant uptake when we actually deploy in the field, because doctors also would want to know that how it is performing in the younger age group, and we have been reported, we don't have huge studies to kind of substantiate that, we have been reported that they also feel this is an adult algorithm, there is no pediatric specific algorithm has been designed. They have been seeing this as a useful adjuvant to their clinical decision, not from a broad standpoint of some findings for interpreting the difficulties in interpreting findings has been solved. But we also understand that our algorithm need to be much more specific to pediatric. We are in the process of enriching that. One of the approach what we are taking is that we have kind of benchmarked that with the Union Atlas, which was recently released, and also tried to kind of call out the severity and non-severity, which has been designed in there. Do you see kind of value in that kind of approach, or do you propose a different approach?
I think that's great. First, I just think any data that's out there, any work that you and other vendors have done, really, please share it, because I think the community really is excited and would love to hear it. And even from the perspectives of the providers in the field, I think that will help. And I think part of what I think is important is, how can we collaborate to kind of work and say, how can we ensure that the tools, either in their existing form or, it's always great to think about how we can improve them, how can we ensure that it's achieving, the clinically relevant goals for childhood TB? And part of it, as you highlighted, is for initial screening and triage or adding confidence.
Correct.
And then the other piece that you mentioned, an important thing, is severe versus non-severe.
Yeah.
I think there are, again, unique, uses for CAD and similar solutions for children that we should highlight. One is the new 4-month regimen that was shown by the SHINE trial that has, the potential limitation that it relies on chest X-ray abnormalities, which again brings us back to the challenges that I mentioned earlier. And so could CAD help enable that decision-making process? Is really would be helpful, because you can imagine dropping down your duration of treatment by 2 months is a huge benefit for children and families. Other things would be, again, the majority of TB diagnosis will be clinically, and so how does CAD fit into these treatment decision algorithms as either at overall score or individual components of the evaluation? And then lastly, I think there's just you have to all remember that a lot of the childhood TB cases are related to having TB contact, and that children are a big part of TB screening and contact investigations, with the recommendation that if they've been exposed and they're under 5 years old, that they really should be getting into preventative therapy. And you can imagine that there's a potential role, especially as we've seen that many children and individuals may not have symptoms. So there's a potential limitation of symptom-based screening.
Correct.
And that's where adjunctive X-ray imaging could be valuable.
Correct. So one of the approach what I just mentioned about, like, we are based on the SHINE trial, and also there could be a value addition of dropping down the treatment duration. Our thought process of segmenting it into severe and non-severe. But on the other hand, we are also thinking, because still there will be challenges about deciding on, because one is from a clinical decision standpoint versus a triage standpoint, and in pediatric it is the requirement is, I believe, it's more clinical decision support system than a triage system, because it's like we don't have much tools to augment your suspicion. So the other idea we are thinking about, our AI engineers are thinking about, is can we have a master data set of proven TB X-rays as a digital command center? Through foundational models, the clinician can ask questions. Okay, this is an X-ray taken by a kid. The AA classification is this. What happened to similar X-rays? So this digital command center is a repository where through conversational AI, it will come back and say, hey, 60% of them are more likely to be tuberculosis as an outcome, and treated and kind of successfully completed. So that probably builds the physician's confidence to classify that as TB versus something else.
Yeah, and I think that sounds very interesting. And I think engages the physicians more. And I think one thing I'm sure you're more aware than I am is how do you build partnerships between the AI and providers?
Correct.
And how do you ensure that physicians and other clinical providers feel that they can trust the information and that they have a role in the decision making? If we view it only as a black box, you have TB or not,
Correct.
There might be a barrier. But I think having that feedback and relationship with the data sounds great.
Yeah, so the other thing which we are also thinking to have clinical parameters and some contextual information, like a history of contact, coughing, failure to thrive, weight, or some parameters to kind of add wastage to the decision. So that will have, that scoring is already there with WHO and also with the Union Atlas. So we will have a much more conversational, not standalone radiology. So we will have radiology plus some clinical parameters driven decision making systems. That's how we are planning to head.
That's great. I just encourage you to form partnerships with the local TB programs, because right now they really are actively thinking about clinical algorithms for children and either adapting existing ones or working to disseminate theirs. And the more that you and others that are developing these solutions can align with the existing standard of care or the emerging standard of care in terms of the evaluation, the more from an implementation standpoint it would all kind of work together because you'd be able to input your solution into the already the workflow.
Correct. So just a question out of curiosity. So once, let's assume that we will have our algorithm maybe in another couple of months or 3 months down the line. So will the platform which you're creating about the data sets will be a good platform that get this evaluated? Is that an idea?
Yeah, I think the idea, at least from an accuracy standpoint, I think what we're working to develop as part of this capture consortium is a way that if you have a solution that you'd like to be evaluated on, so if you feel like it's showing value in children 3 and older, it's beneficial for you and for the community to know, okay, overall, how is it performing? Are there certain features, that it does quite well, like cavity, whether it's a child or an adult, it might perform well, right? Get feedback on how it performs. That's the first phase. And then the second phase is really, how can we improve? I think any AI-based group that had then access to childhood TB well-characterized x-rays, would benefit from having that and being able to improve on their performance, which again would be beneficial to the vendor, but then also obviously very important for the community in ensuring the confidence of the performance.
Perfect. So this is just not related to tuberculosis because I'm sitting in front of a pediatric infectious disease expert. So just want to understand, like from an AI company standpoint, not necessarily an image thing. Do you see what kind of AI solutions or digital solutions we can contribute to pediatric infectious diseases?
Sure. I mean, I think you bring up an important point about how children come into care, whether for TB or otherwise, and that the reality is that they're often coming in with non-specific symptoms, cough or fever, and I think we have to think more broadly and less siloed to think that a child's coming in, let's put in our TB solution into it. The reality is a child is coming in, they have prolonged cough, fever, and as a frontline provider, your question might be, yes, is it TB? But more broadly, it's to say, okay, are we dealing with a viral respiratory infection? Is there bacterial pneumonia? Is there asthma? Is there other causes, which can be wide and varying? And a more applicable solution is to think about how can some of these solutions be applied to a wider range of respiratory conditions and fit into those pipelines, so that an individual comes in, they get either an X-ray, if you're talking about CAD-based systems, or sound-based, testing, whatever it is, and how can that guide that frontline provider to make, quite difficult decisions. I think overall, it's really important to recognize that children are coming into care with non-specific symptoms, and providers need to make decisions, yes, about TB, but are they going to start initial treatment, whether for an infection or for asthma, other respiratory conditions, are they going to go to the hospital? Those are really the tough early decisions that need to be made, and I think there's a really important role for these to go beyond, purely TB, and to guide, frontline providers to really think through the next steps for them.
Perfect. Thank you so much for dropping down to our booth and then having this conversation. It was so enriching from the standpoint of science and the development, and also research happening in this thing, and also a lot of promising comments came from your side. It was a pleasure talking to you, Dr. Devan.
Thank
you so much.
Thank you.